Meniscus repair, as we all know, though it has been done for quite some time, but it has caught up quite recently when all these devices came up and when we started recognizing that the results are much better if we repair them timely. Out of all the tears, probably the bucket handle tears we've seen for quite a long time, the radial tears were probably the thing which we all were afraid of. Why? Because if we leave it, the results are disastrous. Repairing them was not never very easy. Why? Because in the excellent presentation, the first presentation that we had, the circumferential hoop stresses that actually prevent the meniscus from collapsing, from extruding. Once a radial tear happens, those hoop stresses, they create havoc inside the knee, and the meniscus, literally, if you don't repair it, or in case you cannot repair it, you remove it, the meniscus is probably going to create other changes also, cartilage changes. It can be a very small tear to begin with, and it progresses gradually if it's not taken care of. And finally, the final outcome might be a parrot beak tear or a complex tear. Repair of meniscus radial tears specifically, we all started with the normal horizontal sutures as we do with bucket handles, as we have seen previously. Then paper came which said the cross stitches, if we take it in this X pattern, they are much more, they are much stronger as compared to the parallel stitches. And finally, something like a combined thing came up, which is kind of a ripstop design, so that your stitches, they don't come out even if the patient bears load on them. So these are many studies. My presentation is basically a video presentation, and some of the videos are not mine. I have borrowed it from Smith and Nephew website for the purpose of clarity, because these are really good videos and they show exactly how to approach these tears. So starting with identification of the tear, here we are going with the horizontal sutures, which has been done from time immemorial. So what you do is, we have taken these, we have already taken, I'm sorry, we have already taken these stitches. So the device that we can use to take these stitches is, there's a specific device from Smith and Nephew, which is called a Novo stitch, which is something like Express-U or the Scorpion that we use for cuff repairs. So you go inside, you bite, the needle comes up, the thread comes out, you take two stitches on both the sides, then you pass your, if you want to use the fiber wire, you can use a fiber wire, or you can use a normal, if you have an Athibond, if you are comfortable with it, the patient, any kind of thread that you want to use, and you can take a horizontal stitch with that. I have exactly how we take the stitches, I have that in the video. So this is the device, comes up, and the sutures come up, then you take the second suture, before these devices it was not very easy to do these things. You could have done, as we have already seen, outside in repair, inside out repair, but radial tears are most of the times in the middle and body, so they're not very easy to approach from outside. So all inside with these Novo stitch and other devices, it has actually become quite convenient to repair these. So this is the second horizontal stitch taken. There is an animation on the left side where you see how these stitches come up finally, and this will recreate the circumferential tension forces. This won't, the hoop stresses are restored, and there won't be any further enlargement of the tear, and it won't progress to a bird beak tear or a large complex tear. So this is what we were talking about. Initially, it was a radial tear and it progressed posteriorly, and then along the capsular margin in the red zone, it came off like a beak. That's why it's called a parrot beak tear. These type of tears, how they are different, because you have to convert them. First thing that you have to do is you have to stitch the horizontal surface into the capsular margin, and then finally you make it into a radial tear, and then reduce the radial tear as you did earlier. The second thing that can be done is you reduce the radial tear first, in the same way as we already demonstrated with the use of Novo stitch, or if you have your shoulder devices with you, you can use them also. And then you the complete thing can be fixed to the capsule, as we do with the bucket handle tears. So parrot beak tears, though, as we discussed what meniscus should be repaired. If they are repairable, then only we should attempt these, because if it's an old tear with synovialized tissue, I don't think there's any point doing these things. So initially the parrot beak, the horizontal portion was repaired to the capsule, and then in the same way that we did the earlier repair, the beak is then being sutured to the horn part, to the part which is there. So the second stitch goes in the main body from the beak, then with your and then you take your knots and the meniscus reduces. So the purpose here is to recreate the proper anatomy to the best of whatever you can. Sometimes the repair in these, especially these complex tears, it might not be anatomical, but if you can restore that tissue, that shock absorbing mechanism, and if you can, the hoop stresses can be. It can be after the repair, if the meniscus can withstand all the load that occurs on the on when we put tensile load on it, then your job is done. Then you probably prevent arthritic changes in the future. So this is the final stitch being taken. I'll just forward it a little bit. So this is another parrot beak tear. So you check whether the how far, how long is the tear, so that you can in your you know what exactly you have to do. You can think about the kind of repair, the type of repair that you want to do in this patient. Then you freshen up the edges. And once the edges are freshened up, then you go forward with your repair. So this is the novo stitch that I was talking about. The suture is taken and the knot is being put. Once the knot is secured, the meniscus falls back into its normal anatomical position. The second stitch is this is the all inside implant. This is whatever you want to use, fast break, sequent. There's so many available now, or Depu Mitex implant is also good. So another suture can be taken by that. And finally, with the Novo stitch again, you reduce the whole thing to the capsular margin. So in these kind of complex tears especially, it's very difficult to maintain the normal anatomy. So even though there's slight overlapping there, but probably this is still better than removing the whole menisci if it's a young patient. And maybe the nature takes its course and some changes take place, and though the final thing that is being done is to reduce, to make it a little inferior so that it doesn't impinge on the cartilage. So you try your best in these complex tears, you try your best to restore the anatomy, but sometimes if you're not able to, then maybe you can be you can stay with a little less anatomical repair, but where you're sure that the hoop stresses are maintained and it's not, the tear is definitely not going to progress even if the patient puts weight on it. So this is the final repair, though not anatomic, but probably the patient, if you would have removed the menisci, the patient would have been in more complications as compared to these kind of repairs. So this is not what we exactly want, but this is something which we have to agree with finally, because of the kind of tear that was there. So radial tears, as we all know, they are difficult tears to repair with the kind of devices that we now have. It's not that difficult as it used to be. should be repaired, because the hoop stresses, you have to maintain them, you have to recreate the hoop stresses again, otherwise it's going to damage the, it's going to lead to arthritic changes later on. And once you repair, the post repair protocol is same as we had with handle tears, 4 weeks of rehabilitation, and the beautiful rule of four that Arvind just now told. I think this is all I have with the videos. Thanks a lot for your patient hearing.